Good evening, students. This is a very important topic which is asked always in the UG as well as PG exam, and simultaneously it is always asked in FMG and NEET exam. This is a very important topic because it is the medical emergency which has got the intervention which has available bedside, proper identification of the cause, and timely institution of therapy can help you save a valuable life. We will be covering it in the following heading, that is the introduction, definition, epidemiology, management. Because in all these four things, you will have the questions, and my emphasis will be that I will acquaint you about the asked question and simultaneously acquaint you what is the important to you to remember for your NEET and FMG exam. We will concentrate mostly on the key concepts areas, and I will invest more time for time being. What are the common causes? It is one of the common causes, and there are clinical scenarios, particularly upper GI bleed, lower GI bleed, occult GI bleed, and obscure GI bleed. What you will find that this is an important cause of hospital admission in most of the cases, and if we address it thoroughly, you can definitely save a valuable life, and we can prevent the morbidity, which is largely possible by the medical therapy. So, what is the hematemesis? Hematemesis is vomiting of blood. It indicates that there is the vomiting occurring proximal to the ligament of Krebs. And what is Malena? Malena is again the passage of black tarry stool. Why tarry? Because the iron has converted to the acidic medium to the ferric form, and it is foul smelling due to action of the iron with the intestinal bacteria. And how much minimum requirement for the blood to be present in GI tract to cause the Malena black tarry stool is at least 60 ml. Most of the books say 60 ml, and most of the Indian book also refer to that. However, there is one standard book which says about 80 ml. So when the question is asked whether it is 80 or 60, you adhere to 60. When 60 is not there, 80 is there, you please adhere to 80. What is the cause of the bleed? There is a Cori database which is maintained in the USA. What they talked about is the 56% of them are due to ulcer of them, and out of them, in the large ones, what you are finding that in the ulcer group, 54%, 6% is due to stomach, and 44% is due to duodenum. There are increased causes by the use of drugs, particularly the drugs which are more in common is the steroids. And long-term use of steroid pertains to increased risk of upper GI hemorrhage, and simultaneously also the other drugs such as the acetyl, and that is aspirin. There is the other drugs which can cause pasugrel and all. So these are the things which has increased the risk of the bleed. In epidemiology, what you are noticing here, that the this is very important slide. You have to understand, most of the years in exam it has been asked. What you are finding here, that the variceal bleed has been initially caused the greater chances. Now you find that the variceal bleed in last two studies, that is what they have found, that it has come down. It is far less common, and the gastric ulcer bleeds and duodenal ulcer bleeds are the common causes of the bleed in adults. In children, however, you will note that the ulcer bleeds are far less common, and that is why you have to understand, in children studies, the variceal bleed outnumbers the outnumbers the ulcerative bleeds. So that is very important. In etiology, if you come to that, the major cause, again, this is from Indian book and published in Indian Journal of Gastroenterology, and which is a respected journal. The major causes are peptic ulcer diseases, esophageal and variceal bleeds, hemorrhagic gastritis, esophagitis, duodenitis, and mallory-Weisstiel. These fanciful names are there. Don't say it first because it is far less common. Angiodysplasia is found in 5 to 10% of the cases, and upper GI malignancy is far less, as I have shown in my previous slide. So this is the way it has to be. Anastomotic ulcers, particularly PUD ulcer, bariatric surgery ulcers, are also known, but it is common in the small subset of the population, and these are the ones which you have to be careful about. Refluxes is the, again, vascular ectasias. There is the familial history in that. If you get in a case-based scenario, familial history, reflux can come to that. There are other small causes in which you have to be worried about. But I will emphasize for the NEAT and FMG, the causes, major causes, you have to remember the ulcerative diseases, variceal diseases, esophagitis, hemorrhagic gastritis, duodenitis, and three vascular anomalies I have talked about. And most of them are very well recognized. When you take the clinical history, what is important, that is the bleeding etiology and historical clues. Because now the questions are always asked on the clinical based scenario. The Mallory-Weiss syndrome, there is emesis before hematemesis, and there is the element of alcoholism. So that is important. If there is the alcoholic binge, then after vomiting and then after bleeding, the chances of Mallory-Weiss tears is far higher. Esophageal ulcers has got odynophagia, means there is difficulty in swallowing. There is the gastric esophageal reflux diseases. Esophagotoxic pills, particularly you heard of the methotrexate. There are the bisphosphonates. So these are the drugs which cause the esophageal pill ingestion gastritis. And if somebody is taking it, it can be taken into the account. Esophageal ulcers, peptic ulcer disease is typically, it is the right upper quadrant pain, and it is associated with non-steroidal anti-inflammatory agents, aspirin, and like that. The stress gastritis, particularly in ICU, in the cases where there is a respiratory failure, accumulative acidosis, multi-organ dysfunction. There is the bleeding manifestation with hypotension, the burns. These are all the chances of stress gastritis, and it should be borne in mind. Variceal and portal gastropathy, if there is history of alcoholism, cirrhosis, antral vascular ectasia, particularly related to renal failure, cirrhosis, that is important. And if it is vascular ectasias, we have to address it aggressively. Malignancy, if you find weight loss, cachexia, early satiety, and then associated with the epigastric pain, we can think of malignancy. And associations of particularly the lymph node, we have to check for that. Angiodysplasias, particularly with renal failure, hereditary hemorrhagic telangiectasias, these are the ones in which there is the renal failure and the angiodysplasia. There are known fistulas in which the repair can be curative, and if we take the proper history, we will diagnose it very easily. What are the risk factors? This is very important to remember, that the risk factors for the development of upper GI bleeding, because what it is now world authorities accept, that the upper GI hemorrhage to a great extent is iatrogenic, means you and me cause it. So that is why there is the enough evidence and the emphasis which says that there is a history of upper GI bleeding, history of aspirin use, the people with H. pylori infection, particularly in the poor subset group who are not using UV irradiated water, anticoagulants and antiplatelet therapy for long time. Erosive gastritis drugs, particularly methotrexate, bisphosphonates, and like that. Perioperative period, particularly in the cases where the anastomosis are offered. ICU admission with hypotension, particularly because for the clearance of the gastric acid, enough circulation is must. Otherwise, this is accumulative and it further to lowers the intraluminal pH and it causes more of the stress. And this phenomenon goes on and it causes more of the ulcers. Zollinger-Ellison syndrome I have already covered. So these are the ones which is the risk factors for upper GI hemorrhage. What I have shown you is the UGI image. What you are finding here, this black one is the bleeding gastric ulcer. This bleeding gastric ulcer, if you can find, you can easily treat it with adequate therapy and you go ahead. What you are finding is the duodenal ulcer with visible vessel. You see here, this is the duodenal ulcer with visible vessel. So that is very important. These images have all been already been asked from the NEET exam, and that is why I am emphasizing them. Please go through them and benefit. This is the clean peptic ulcer with clean base. Why it is important? If we find like this, we can safely assume that it is a benign lesion. And if we find hemorrhages and if you find the everted margins and like that, then the malignancy is much higher in the card. So if you find this type of ulcer in the NEET exam 2015, they have asked what is the therapy of choice. In that you have to write PPI and sucralfate only. You need not write surgery or further investigation because they are testing the concept whether you have got clean base ulcer concept or not. What you are finding in is that you are finding the ulcer on gastric adenocarcinoma. You find that large ulcer with the margins, rugged margins. These are the rugged margins you see, and this is a large ulcer. If you find this type of picture, the malignancy is far higher in the card, and that is why we must educate our students. This type of malignant pictures we get, we must investigate it thoroughly. We immediately send him the patient for the CT scan. We evaluate with the PET, and we refer him to the oncology center at the earliest. These are the hemoclips, post variceal bead clips, which is shown. And again, this has been asked in the exam. You see, this is a hemostatic clip which is put in, and what it is offering, it is offering the hemostasis. Immediately, large bleeders, if you offer it, they last for some time, and then after they are excreted out in the stool, and it is a life-saving thing. Initial patient evaluation, what is very important is that the severity of bleed assessment. If patient is in shock, the blood loss is more than 25% and it is a severe bleed. If there is postural hypotension, the blood loss is 10 to 20% and there is moderate bleed. And if the blood loss is less than 10%, there is no bleed the mild bleed which can be addressed with the oral therapy and observation. But the moderate and severe patient has to be admitted, and it must be emphasized they have to be treated aggressively, and this can't be disposed of without the endoscopy. For normal one, you assess clinically, and in resource poor setting you can dispose, but in the adequately equipped center you have to evaluate them. So this is the very important one. This is the key parameter to evaluate a case, and that is why it has been asked multiple times in the NEET exam and the FMC exam. I have particularly brought the slide to explain the concept. Resuscitation, what is that? The person is bleeding, he is come in hypotension. First and foremost is the airway protection, airway monitoring, endotracheal intubation if there is there. Hemodynamic stabilization, a large intravascular venous access should be there. At least 18 gauge needles should be put in, and 16 gauge is preferred, at least 18, and you will start with the intravenous fluid. Colloids should be the immediately available, and then after fresh blood or fresh frozen plasma or platelet as per the indication. Nejo, if there is a very severe problem, you can think of erythropoietin. Some studies I talked about, and even PGI exam also has work. After this, if there is there bleed occurs and for resuscitation, is this drug used? It has been asked, and it has been erythropoietin is mentioned in the Harrison also. You must use that. Nasogastric oral administration, that is what this is large bore orogastric tube is passed to assess whether is a fresh bleed or no. If there is a fresh bleed, it is a dire emergency. You have to take him for the endoscopy, or if there is endoscopic center is not available, then I will tell you what is the equivalent therapy which is there. And clinical and laboratory monitoring, you must do the vital signs, particularly the pulse. If there is tachycardia, BP, you must ensure the postural hypotension or there is hypotension. And then after, capillary filling time in the children. And these are the ways we have to emphasize, and then only it is possible. Electrocardiographic monitoring is important because it will give you idea about how to go about that. Hemodynamic monitoring in high risk patient is important, and endoscopic evaluation, all fresh bleed cases, it should be done immediately unless unless it is sure that we don't have it and patient needs transfer to the higher center. This question is always asked, the chronology of evaluation and resuscitation. The first thing is airway, second is the breathing, third is the circulation, fourth is the evaluation, nasogastric tube evaluation. If there is the fresh bleed, direct endoscopy, no fresh bleed, altered bleed, or quiet bleed, there is the room for delayed investigation. And clinical monitoring, I have explained you, capillary fill time, the tachycardia, then after the if there is the fall of blood pressure, postural fall, and if these are there, we have to evaluate this patient. In hemograms, we have to see that if there is the HB less than 10, they require immediate blood transfusion. And I will come to the criteria by American College of Gastroenterology, and I will explain you further as we progress. The first is the in resuscitation, fluid resuscitation, 2 liter of isotonic saline if there is the low pressure and BP, plasma expanders if there is more than 20% of the fall, and if there is ongoing uh, blood loss, cardiac ischemia, HB less than 10% in that, straight away blood has to be organized, and if possible, fresh blood should be offered because the benefits are far higher than the old blood. And it has also been asked in severe GI bleed, the blood product of choice. It has been asked in the 2017 NEET exam, and the answer is the fresh blood. So, what is the aim of resuscitation? In elderly, at least 30% of the hematocrit to be achieved, and at least 20 to 25% in the young individual. If blood requirement is more than 10, then fresh frozen plasma and platelets have to be added. If it is more than 12, the fresh frozen plasma and platelet both are required. This is the, if more 3 liters of blood is required, warm fluid has to be given. Warm blood can be given, and that is the way we have to manage. Calcium supplementation and serial hematocrit evaluation has to be offered so that the resuscitation should be complete. This question is always asked, and it has been asked in the FMG, what is the goal of the hematocrit in the upper GI endoscopy in a 65-year-old man, and the answer is 30%. At least 10 gram of hemoglobin has to be achieved. So what is the role of this nasogastric tube? Because the 10% present upper GI hemorrhage may present like the lower GI hemorrhage. So if you know it, you can treat it accordingly, because the risk factors are far different. Lower GI bleeds are the causes are mostly malignancy. Upper GI, it is the varices and the acid peptic diseases. So that is why if you know do the nasogastric tube evaluation, you can come to know with distinctly what is the cause. Second, if there is active bleeding going on, red blood is going on, you immediately take him to the endoscopy and you offer him the local therapy as well as the systemic therapy. If there is coffee ground, means this is the altered blood. It may be quiet also. In this game, there is the room of weight also, and that is why it is important. So, importance of nasogastric tube has been asked many times, and there is lethargy in many center in doing it, and that is why I have brought this point. So thirdly, when you do the nasogastric tube evaluation, you clear the gastric field for endoscopic visualization, and it also prevents the gastric fluid aspiration due to clearing of the fluid. And what are the problem with that? If there is a closed pylorus, then you cannot pass it, and then there is problem. If there is a bilious one, again there is the problem. But these problems are far less compared to the benefits of the therapy. So that is why in normal condition and with adequate support, we must go for the nasogastric tube evaluation. So what is the this question is always asked. That is why I have brought it. Rockall scoring center of scoring system of severity of acute upper GI bleed. So what are the important? The importance is if there is the a score of less than 3, there is excellent prognosis. Means the only therapy, local or systemic, can cure it. And if it is more than 8, the risk of death is very high, more than 50%. So what we have to do? There are these 5 criterias. That is the age. If it is less than 60, 61 to 79 and more than 80, and the presence of shock, diagnosis means that what is the diagnosis, and whether there is major or minor. So that is why if there is the score is more than 8, there is very high mortality, and that is why at the initial stage you can assess it. Age is available with the patient. Tachycardia or hypotension can be done with the clinical examination. Other diagnosis, particularly post UGI endoscopy, you can find out what is the cause. If there is mallory tear with no lesion, or there is no vascular ectasias, or large lesion is not there, then you can place it in the category 1. So what are the things? This is mostly a clinical criteria with the UGI evaluation. If you have assessed it, you can with good certainty predict the outcome of the case, and you can educate your patient about the outcome. And that is why this scoring system is still practiced, and in clinical based scenario, this question is asked, what is the mortality, excellent mortality, good mortality, and like that. And if there is less than 3, you can say it is the good, excellent prognosis. If it is more than 8, you can say the mortality is high. And that is why this slide I have particularly brought based on the exam scenario. Aim of management is what? You have to bring the pH of uh, the gastric antrum more than 6. What is happening? Because at that more than 6, what happens? There is the adequate platelet aggregation, and there is the adequate fibrinolysis. So what is it is inhibited? So what is happening? That whatever bleeders are there, they stop bleeding. So that is why there is immediate use of proton pump inhibitors. Even what it has been shown, most of the government centers still use the H2 receptor antagonist, but in meta-analysis, which was published in 2005, monotherapy of PPI, that is the pantoprazole, is far superior to the ranitidine or famotidine and placebo in rebleeding and need of surgery. So it goes without saying, in upper GI bleed, you have to give enough the proton pump inhibitor. And what to start with? Usually we start with 80 milligram of pantoprazole and 8 milligram hourly till we get the bleeding stopped. So medical management, this is the aim, this is the medical evidence we have, and that is why we have to adhere to this. Uh, uh, in regime, how long we should give the infusion? We should give infusion up to 72 hours. And what is the reduction of bleed? If there is infusion given for 72 hours, the rebleed can reduce from 22.5% to 6.7%. The 6.7% is far important, and that is why we have to offer this. And PPI based therapy is useful for the patient with peptic ulcer diseases in which there is endoscopically high stigmata of bleeding. I will come to that how it is done, but important is we have to understand it. Endoscopic management, what is there? We can give the adrenaline 1 by 1000. These all has been asked in the exam, and that is why I have put it. What are the agent used for endoscopic management? The endoscopic management can involve adrenaline 1 by 10,000, which can be given at the base. And what it does, it causes vasoconstriction, and with the vasoconstriction, the bleeding is stopped. Absolute alcohol used as the chemical cautery, and it can close that. Saline, again, it works like the prevention of bleed by the early thrombosis. 50% dextrose have been used in resource poor settings. Fibrin glues are used, and sclerosants are used, that is the pilidocanol, sodium tetradectyl sulfate, ethylenominolate. These all have been used with the success. We will come to that, the sclerosant therapy, and this, because again this is also a important question for FMGE as well as the NEET exam. Variceal bleed is the important cause of bleed, and why it occurs, that you must understand. In cirrhosis, there is resistance to the portal flow increases, and then after what is happening, there is increase of the portal pressure. And with the portal pressure, what is happening? The varices are formed, and these varices rupture, and they cause the bleed. So you have to understand this is the way it occurs. And what is the increase of portal pressure? What it causes? Decrease splanchnic anterior resistance, and again the portal flow blood is increased, and that is why this circle, vicious cycle, keeps repeating, and that is why this chart is important, because when you come to the therapy, how to help with the beta blockers, if you have this concept, you can safely use it and prevent it. And simultaneously, again a neat question: what is the cause prevalence of esophageal varices in cirrhosis? Higher the child score, which Pugh child score, you know it, it is asked in the exam, and higher the score, more is the bleed. overall bleed is something like 15%. Child A, it is 40%. Child B, it is 65%, and child C more than 80%. And that is why there is the liver failure issues and simultaneously bleeding occurs, and this causes increased mortality. And we have to understand, higher is the Child Pugh score, more is the prevalence of esophageal varices, more is the chances of bleed, and that is why it is important. And Child Pugh score, if you remember the clinical based scenario asked on this, you can easily answer. This is the endoscopic picture. What is important here? This is the clean stomach, and what you are finding here, that is the small varices, and these are the large varices at GE junction. So what is there? It is used for the classification of the severity and further to planning of the therapy. So that is why what is in exam it will be asked many times. The large varices have been asked, what is the risk of rebleed, and the answer has to be given. And if you don't identify this image, mostly you can have the problem. So what is the mortality? Mortality, if you come to that, in 3 years, there is more than, in 3 years, there is more than mortality more than 60% in the severe ones, and that is why it is important. When you come to the variceal wall thickness, what is there? This is the important chart in which what you see, there is the transmural pressure which is there, and tension. The intra variceal tension is relates to the chances of rebleed. The intravaricial tension relates to the radius. Higher is the radius of this varices, more is the chance of repeat. High and more, lesser is the thickness of the vessel, varices, more is the chance of that. So that is why bigger one and the thinner one have to be identified and endoscopically worked on. And that is why this concept of variceal wall tension and major bleed has been brought into. So these are the ways we have to go with that. Decreasing the portal pressure, what it is does, the transmural pressure comes down, the variceal radius goes down, and that is why we can go with that. And that is why we have to understand that the earlier therapy helps in adequate control and more survival. Varices at the risk of bleed is the, what is the more of the intra uh, variceal pressure gradient, more is the chances of that. And if they are at the lower third of the esophagus, again there is more of the chances of the bleed. And if the red wall markings noted, means that the thinned out vessels, more thin vessels, more is the risk of the bleed. Large varices increase risk of the bleed, and that is why the chart I have shown you, that is very very important. And concept is, you identify the larger varices and the thinner vessels, and then you treat it endoscopically in the interest of the patient. What you are seeing, that this is the variceal hemorrhage, and what is the, here you are find, that is the large varice with the redness. So what is there? It is the predictor of the bleed. So this again it has been asked in the PGI exam. What you are finding here, there is the large varix with the thinned out one. So that is why this one is the imminent bleed is possible. If you find this type of picture, and in clinical based scenario, if they asked what is the therapy of choice, you must say it should be endoscopically tackled by the banding, and that is why this is important. This is the bleeding esophageal varices. You can see this is the bleeder and it is bleeding profusely. So what is the endoscopic ligation means? That you identify the bleeder, you ligate it, and after ligation you come back. What will happen with this ligation? What will happen? It will peel off from the thing, and it will give you a clean esophageal surface, and the risk of bleed is reduced. What you find this is the large varix, again large varix, but the reasonably uh, well preserved gastric wall, and that is why this needs to be tackled. But if you are given the large varix with the thin out wall, you have to say if you have to treat A or B, which one earlier, or B and A together. It has been asked in the AIMS exam, and what is there? Then you have to say the one with the thinner margin has to be addressed first, and that is why these type of questions are asked in the All India exams, where there is the elimination process is important. This is the important thing, again taken from the Foster textbook of GE. What it is important, you see this risk factor for the bleeding. Early rebleeders are older the age, severity of initial bleed, and like that. And that is why it is important to identify every bleeder and treat it adequately. In variceal bleeds, the treatment modality I have discussed. Now we go to another one modality of treatment, that is the beta blockers. And in beta blockers, non-selective one, propranolol is the drug of choice. And how does it help? It helps in multiple ways. It blocks the beta 1 receptor in heart rate, reduces cardiac output, reduces total pressure. It also reduces the collaterals. And at low doses, what it causes? There is the block the beta 2 receptor in splanchnic circulation, due to which there is the increased alpha adrenergic stimulation, and with the splanchnic vasoconstriction, what will happen? The reduced portal flow and reduce the portal pressure. And if the portal pressure is reduced, the variceal pressure is further reduced, and that is the happy situation. The risk of rebleed is far less. This is the terlipressin. What is this? This is given to reduce the splanchnic circulation, and with that the pressure is reduced, and it can be life saving. What is it is studied? It is studied that it is as good as the preventing the death and the morbidity, as good as endoscopic one. It can be given at the bedside, it can be continued for 5 days, and it also been known to prevent the hepatorenal syndrome, and that is why this drug is in popularity, and it is available bedside, life saving, and even a physician, a general doctor can give it. Somatostatin, it is the far better one. What is that? It is the effect is as good as the terlipressin, but the side effect, that is the is far less. So that is why this drug is now accepted. It is it reduces the bleed. It is life saving. It can be given as early as immediate. It can be given in infusion, and it saves life as good as the endoscopy. It can be given till 24 hours of the bleed free interval, and it can be given as long as 5 days. And what is there? It can be used in the severe bleeding stage also, and it can save life. Octreotide, again 50 milligram bolus and 50 milligram hourly infusion can be offered, and that can is known to have that. This question is often asked in the All India exams, and that is why I have brought this slide. Because why, which is better, bland ligation or a sclerotherapy? The band ligation, if you see, it is the older therapy, sclerotherapy. Band ligation is the recent one. Recurrence of bleed is less with the sclerotherapy and more with the band therapy. Why it is there? Because there are the specifically targeted vessels are there. Complications are far less. The therapy is more standardized. The session requires for obliteration is far less, because in sclerotherapy multiple sessions are required. In active bleeding control both are equal. And if you see, if there is somebody is in prophylaxis in beta blockers, it is not recommended. But even if somebody is in beta blocker, it can be given. The survival, it is far better and than the sclerotherapy. And lastly, it is the costlier than the sclerotherapy, because the cost of the bands are phenomenal, and as the it is the mostly imported, this is the limitation of availability also. So this is the important slide. You have to understand the sclerotherapy versus the ligation, and what are the benefits, you have to understand, and it will help you in your exam. This is important question which is often asked. Sangstaken Blackenmore tube. This is usually asked by the examiners, particularly in NEET exam or lower rung exam, not in all India exams, and that all India national repute institution, because this is a time buying procedure. It is not curative. So what you are offering, you are passing the Sangstaken Blackenmore tube, and you are inflating it. With the inflation, what you are doing? You are doing the pressure ligation, pressure support on the bleeding vessels, and you are trying to help the buying time till you take the patient to the specific center where the therapy can be offered. What are the complication of the tamponade, balloon tamponade? It can be chest pain, vomiting, nasopharyngeal bleeds. It can have necrosis. Their ulcer can be there. Ruptures are reported. Aspiration pneumonia is there. Hemoptysis is there. And if there is no synchroning in the deflating, there is the severe aspiration, and even deaths have been reported. But in the resource poor setting, when there is the active bleed is there, still it should be offered, and it should be used with caution. Tips is the trans jugular procedure. What you are doing, you are making a shunt to prevent the bleed. And why this is you are doing it? To prevent the rise of the pressure. So what are the important event? There is the severe ascites, there is the recurrent bleed. These are the cases in which the tips are offered, and they can be that. What are the complications? The complication is the early encephalopathy can be prevented, and this is again a morbidity neither is prevented, but it can help in the quality of life in the patient who has got the problem. So what is the how to approach? This is important. That is, if you suspect the variceal bleed, you first and foremost is the resuscitate. In resuscitation, you have to give the airway. There is the circulation. Then is the nasogastrial aspiration. If there is the fresh bleed, you have to take it for the endoscopy. If it is not fresh bleed, you can wait. You have got the time. And in there is the fresh bleed also, you have got two options. Either you have got the endoscopy, you go with the endoscopy, you identify the bleeders, you stop them, and you are happy. If there is no endoscopy is available, what is the problem? You have to go with the Terlipressin or Octreotide. And if you want to buy time to take my patient to the hair center, you can put the Sangstaken tube and balloon tamponade, and you can take them to the hair center. If the bleeding is stopped, it is good. If it is not stopped, it is recurring, then the tips is the answer. Even if the tips is not working, then surgery is the only answer. And that is why we have to be prepared, some of the patient for that. So why it is I have chosen the topic, because in every year this question is asked in the exam. If you prepare it, you will definitely catch 2 or 3 questions for your exam. And I am very sure that it will help you for the preparation of your exam. Thank you. God bless all of you. Bye.